today I'm going to talk on post-transplant anemia. As you all know, uh, anemia post-transplant is a common issue, though it is not very often discussed or talked about. And this is important because this, in the long term, it can affect the graft survival as well as the mortality, and it's been linked to cardiovascular events. So it is all the more important to know what are the causes of post-transplant anemia in the early period as well as the late period, and how to go about its management. So today I will be talking to you under the following headings. First, I will be introducing the topic, then going about its epidemiology, the risk factors of post-transplant anemia, diagnosis and management, the role of ferric carboxy maltose or iron therapy in transplant patients. So post-transplant anemia is an important issue in kidney transplant recipients. As you all know, anemia is a major player in non-immunological causes of graft dysfunction, and the precipitating causes for post-transplant anemia includes a myriad of causes, depending upon the timing of post-transplant anemia. In the early period, it may be due to iron deficiency anemia, due to the intraoperative blood loss, or it can be related to infections, older donor age, rejection episodes, as well as the inflammatory milieu. Again, in case of a single kidney transplant, the transplanted kidney seems to function and only partially restoring the function of the kidney. As a result, there is incomplete correction of the anemia which is noted. And post-transplant anemia likely contributes to chronic ischemic injuries and eventually to graft loss in the long term. So there is what's the definition of post-transplant? I mean, there is no uniform definition. It depends upon the timing of transplantation or in terms of severity of anemia. But by and large, most authors have suggested to classify post-transplant anemia as early as well as late. Early, this classification because the etiology tends to vary, and early is supposed to be less than 6 months after transplantation, and late post-transplant anemia, which occurs after 6 months of transplantation and may appear up to 8 years later. The causes of anemia after transplantation tends to differ. For early anemia, as I already said, it is due to the more leading causes iron deficiency, which may be due to the intraoperative blood loss or frequent phlebotomies, or it may be related to the pre-existing iron deficiency the patient may be having, and the immunosuppressive medications, injection as well as maintenance therapy, the infections like viral infections like EBV infections, cytomegalovirus, BK infections, etc., and other infections which are quite common in the early transplant period. Again, the allograft function is also quite important. So those with delayed graft function, those with extended donor criteria donors, so all those that tend to cause early anemia and rejection episodes. Another important cause is the aggressive dehydration. So most post-transplant, we may be hydrating the patient more, and this may cause a dilution effect resulting in anemia. So all these factors need to be considered in the early cause of anemia, and deficiency being the leading cause. And if you look at the late anemia, the most important causes allograft dysfunction, and other causes include iron deficiency, the immunosuppressive therapy which the patient may be receiving, being the tacrolimus, mycophenolate mofetil, as well as the mTOR inhibitors. All of them can cause some bone marrow suppression and can cause anemia. More so with the sirolimus. And again, infections, the late viral infections is an important cause of anemia, which includes the CMV infections, the paroviral infections, the hepatitis B. These infections can result in anemia. And again, drugs are also important causes which needs to be considered. Patients may be on long-term renin-angiotensin system inhibitors, which can contribute to anemia. Again, proton pump inhibitors, use of proton inhibitors can inhibit iron absorption and can result in anemia. Antimicrobial agents, which the patient may be on, like the septine prophylaxis, which the patients may be on, Valgan cyclover. All these drugs can also result in anemia. Acute rejection episodes, finally nutritional causes like vitamin B12 and folic acid deficiency. So all these need to be considered when evaluating anemia in patients in post-transplant. No, like I already said, iron deficiency is a leading cause of early onset of anemia. The gold standard for iron deficiency is iron staining of bone marrow. but this is not often possible. So we rely on the markers like serum ferritin and transient saturation. However, serum ferritin, being an acute phase reactant, it has got its own limitations and may be increased in setting of inflammation and may mask the coexisting iron deficiency. So transient saturation is tend to be more reliable, though this is also a dynamic and sometimes may be affected by inflammatory process. So usually what we look at serum ferritin of less than 30 is usually a widely accepted alternative definition for iron deficiency. And it is at less than 20 percentage. Now going on to why you need to address the post-transplant anemia. What's the need for knowing this post-transplant anemia? As you know, the post-transplant anemia needs correction with transfusions, and this transfusions can increase risk of immunological sensitization, and which might affect the future transplantation. Again, post-transplant anemia is associated with reduced graft survival, decreased quality of life, and it has also been linked with adverse cardiovascular events like increased left ventricular hypertrophy, reduced systolic function, and long-term mortality. So that's the importance of understanding post-transplant because it affects the graft as well as patient survival in the long term. So these were some of the studies which looked into the same. This was a study in the Rabin Medical Center where they looked into around 1,139 patients. They found the prevalence of post-transplant anemia to be around 36.2%. And the conclusion was that post-transplant anemia was associated with increased graft loss and mortality, especially during the first 3 years. And anemia workup is therefore recommended in patients for patients with post-transplant anemia. Again, this another study which looked into which came in Saudi Journal, where they looked in 7 years follow of post-transplant anemia. In this study, they looked into around 145 patients, and the prevalence was around 8.3%. And graft failure was significantly associated with late post-transplant anemia at 4 and 7 years. And the study found that this was also associated with significant graft failure and patient mortality. So that's the importance of understanding post-transplant anemia. And looking at the epidemiology, it varies according to the timing of post-transplant. Early post-transplant anemia is said to occur around 10 to 40% in various studies. And the prevalence of post-transplant anemia is reported to be around 12.5% in a prospective cohort Indian study. So this was another study which looked into the prevalence of post-transplant anemia. As you can see, the prevalence is more common in the immediate post-transplant period and tends to come down further. So it is the most common in the first 3 to 6 months. And this was another study which looked into the factors which is associated with anemia in kidney transplant patient in the first year after transplantation. And this was a cross-sectional study where they looked into 336 transplant patients. And the prevalence of moderate to severe anemia in the study was around 27.4% at 6 months and around 15.2% at 12 months. So what they found was that a lower kidney function, the female gender, a transient saturation below 10% and proteinuria were associated with moderate to severe anemia. And recent intravenous immunoglobulin treatment was associated with anemia at 6 months. And anemia, what they concluded was anemia was quite prevalent, and this might require treatment with erythropoietin and transfusions. Now let us look into the risk factors of post-transplant anemia. So common cause of post-transplant anemia can be divided into the early post-transplant anemia, as already said, the most common cause is iron deficiency, which may be related to the increased phlebotomies, the blood loss, which might happen, and perioperative blood loss, and nutritional causes of iron deficiency or pre-existing iron deficiency. Again, other causes, infections, which can be delayed onset infections like parvoviral and CME infections can result in anemia. And there is erythropoietin deficiency, especially in the single kidney transplant, the kidney, or in case of delayed graft function, acute rejection skin may take some time to recover. So there may be a later erythropoietin deficiency, which might contribute to the post-transplant anemia. Again, there is in late onset, there is the post-transplant setting is a setting of inflammation, oxidative stress, which can result in bone marrow suppression and anemia. and acute rejection episodes, presence of TMA can also contribute post anemia. And in late onset, the malignancies also need to be considered. And again, drugs, all the immunosuppressive drugs, as well as the antimicrobial therapy, ACARBs, all these can contribute to post-transplant anemia. Now, let us look into the pathophysiology of post-transplant anemia. So, as you can see, in case of in a post-transplant, especially post-transplant, there is always a systemic low-grade inflammation, and in a setting where patients are on certain immunosuppressive agents like mTOR inhibitors, all these can result in a decrease in hepcidin expression, and hepcidin because of increase in hepcidin expression, and because of hepcidin upregulation, there is decreased absorption of iron from the enterocytes, because hepcidin causes degradation of ferroportin. Again, there is because of degradation of ferroportin, there is decreased release of iron from the reticuloendothelial system, and this can result in decreased iron stores and the other iron deficiency, which is noted after transplantation. And again, immediately post-transplant, there is certain rise in this erythropoietin production by the new graft, and this might result in increased iron consumption, which might lead to iron deficiency. And immediately post-transplant, there is also there is frequent blood sampling, preoperative blood loss, use of anticoagulants. These all can lead to iron deficiency. So these are one of the few reasons of iron deficiency after kidney transplant. Now, how will you go about diagnosis of diagnosis of anemia post-transplant? So in post-transplant setting, an assessment of the usual cause of anemia should is required, which includes the assessment of red blood cell indices, and then assessment of reticulocyte count, and iron profile, including the serum iron, total iron binding capacity, and transient saturation. Though these the serum ferritin and transient saturation may not be that reliable in patients with transplant, especially in setting of inflammation and infection. However, these have to be assessed. Again, in test for presence of hemolysis should be done when there is clinical indication, especially when there is elevated reticulocyte count or elevated lactate dehydrogenase, or there is indirect increase in indirect bilirubin. So these in such settings, test for hemolysis, peripheral smear follicular cystocytes should be looked into. And then other specific potential cause of anemia by you should also history should be taken regarding the use of medications. Concurrent infections should be looked into. So when do you need to evaluate? You need to evaluate for post-transplant anemia, especially when the hemoglobin fails to normalize in the first 3 months after transplant, because that's the time the new kidney, and takes time for the restoration of the endogenous erythropoietin, and usually the hemoglobin tends to correct by 3 months. If it fails to get correct by 3 months, or late onset, late in the course, when the hemoglobin is less than 12 in less than 12 in females, or less than 13 in males, or postmenopausal women, you need to evaluate for post-transplant anemia. And in certain specific cases, like you have to do an infection workup, and late onset parvoviral testing for serology may also be indicated. Now, let us look into some of the few rare causes of anemia post transplant. One such entity is the passenger lymphocyte syndrome. Now, this is a rare cause of anemia resulting from immune-mediated hemolysis in the post-transplant recipient. This is a situation which is seen in the immediate post-transplant period, and usually in the first 1 to 3 weeks post-transplant. This is due to the viable donor B lymphocytes, which gets transferred with the organ during the transplantation, and they produce antibodies against the red cell antigens, usually leading to hemolysis. Usually, it occurs when a O group donor gives the trans to the A or B recipient. Also in Rh positive, Rh negative to Rh positive also, this passenger lymphocyte syndrome has been described. And this is usually a self-limiting condition. And as the ABO antibodies usually tend to clear out within a maximum span of around 3 months. Now, the laboratory findings, you can see a rapidly decreasing hemoglobin level, and there is a sudden onset of intravascular hemolysis with low haptoglobin raised LDH, and ECT may be positive. The serum antibody is usually predominantly IgG, but it can also be IgM. Antibody production usually decreases as the lifespan of the lymphocytes comes to an end, and usually persists for a median of 5 weeks. So this is a rare cause of anemia in the immediate post-transplant period. And if once it is diagnosed, the treatment involves a transfusion with the donor group RBCs or group O RBCs, and avoidance of ABO incompatible blood products. And again, the immunosuppression, the corticosteroids are often increased, and those with very severe hemolysis, plasma exchange may be used to reduce the antibody titers. Also, use of intravenous immunoglobulin as well as monoclonal antibodies rituximab have been tried in various studies. Other common cause of uh, post transplant anemia is the parvoviral infection causing pure red cell aplasia. So this was our experience which we shared in the recent con, and we had around 6 patients with parvoviral infection post transplant. So their mean age was around 40.5 years, and majority, three of them were males and three of them females, and all received injection with ATG. And the mean hemoglobin was around 6.7. And all these patients, the parvovirus IgM and IgG was positive. So diagnosis was based on the par anemia, as well as the parvovirus IgM positivity and reticulocytopenia just noted. So all these patients' clinical presentation was refractory anemia in all the patients. The time of presentation was 3 patients presented less than 1 year, and other 3 patients presented after 1 year. And this was a bone marrow finding, which you can see the giant proerythroblast as well as the hypoplastic marrow, and giant proerythroblasts are usually findings which suggest parvoviral pure red cell aplasia. And you can see the inclusion bodies. So this was after treatment, the hemoglobin level improved in all the patients. In fact, in one of the patients, the hemoglobin increased to around more than 18, and he required repeated phlebotomies to bring back the hemoglobin normal. So most of the patients had improvement in hemoglobin following treatment. And the treatment included intravenous immunoglobulin, which was given around 2 milligram per kilogram dose, and immunosuppression was reduced, and mycophenolate was initially stopped, and it was restarted later. And the mean hemoglobin at 6 months post treatment was 9.8. So here we had a prevalence of around 0.004%, and the diagnosis was based on with bone marrow biopsy, the serology, as a PSA analysis was not done in our patients, and 60% of patients present with first year of transplantation. And this should be considered as a important differential diagnosis in patients with refractory anemia with reticulocytopenia, and the serology often gives the diagnosis. And relapse is quite rare, but some patients may have relapses requiring multiple doses of IV immunoglobulin. And this is another rare cause, which tacrolimus-induced pure red cell aplasia is also been reported in various studies, where the switching over from tacrolimus to cyclosporin corrects the anemia. This entity should be remembered if the patient is having a significant anemia post-transplant in the early post-transplant period. Now let's just look into the management of anemia post-transplant. So anemia post-transplant can be managed with erythropoietin stimulating agents, iron therapy, the PHA, prolyl hydroxylase inhibitors, as well as blood transfusions. So commonly you use this erythropoietin stimulating agents, which you use in the immediate post-transplant period to improve the hemoglobin, as well as in the late post-transplant anemia also. So here the starting dose is usually 50 units per kilogram per week, and the different forms of erythropoietin can be used. Like the long-acting ones are also used. The problem with erythropoietin stimulating agent is one is it requires parenteral dosing. Other is there have been high concerns with increased incidence of cardiovascular, malignant, and infection-related deaths with the use of erythropoietin, and uncontrolled hypertension. These are some of the challenges when using erythropoietin stimulating agents. And regarding the iron therapy, both oral as well as iron therapy has been utilized in the management of post-transplant anemia. And the newer class of agents is the hypoxia-induced porolyl hydroxylase inhibitors, which have been used, but few large studies are to be there to recommend its usage. The roxadustat is the one which has got maximum case series and studies where it has been used 3 times a week, and it has been shown to improve the hemoglobin levels with good safety performance and with stable allograft function. And blood transfusions, the problem with this, the high incidence of donor-specific antibodies and risk of sensitization. Now, let us look into the role of iron deficiency anemia in the role of iron therapy in iron deficiency anemia in kidney transplant patients. Now, iron deficiency can be treated with either oral or IV iron preparations. In patients with congestive heart failure and CKD patient, the iron supplementation parenterally has a superior efficacy to correct the iron parameters compared to their oral preparations. One of the reasons is that in post-transplant, there is an increased inflammatory setting where there is a upregulation of hepcidin, and hepcidin will prevent the intestinal iron absorption. So parenteral iron theoretically tends to be more efficient in post-transplant setting. And also oral iron therapy is associated with increased side effects like abdominal pain, constipation, or diarrhea, and compliance is usually poor. And this is a data which compares regarding the oral versus iron therapy and the human microbiota. Now, oral iron supplementation can change the gut microbiome in favor of bacteroids and enterobacteria, with in the expense of the symbiotic lactobacilli. And these bacteroids, and they have they express siderophores, which need iron for their growth. And because of again in kidney transplant, this host microbiota profile has got impact on the diarrhea, graft survival, as well as incidence of infection. And when because of overgrowth of the pathogenic species are known to express these siderophores and need iron at the expense of iron independent lactobacilli, can be speculated that the intra-intestinal iron supplementation has a detrimental effect on the microbiota in kidney transplant recipients. And abundance of this intra-intestinal iron increases risk of enteritis. So that is also one thing in favor of an IV iron therapy. So because of these unfavorable effects of oral iron therapy, IV iron may be preferred. And ferric carboxymaltose and iron sucrose injections have been proven to be effective and safe in anemic or iron deficient kidney transplant recipients. And IV iron supplement compared with oral treatment did not increase the risk of infection in a study of 102 kidney transplant recipients. So this is a study which looked into the impact of immediate post-transplant parenteral iron therapy on the prevalence of anemia and short-term allograft function in a cohort of pediatric and adolescent renal patients. So where they routinely supplemented patients who are transplanted with parenteral iron, they found that this was associated with a lower prevalence of early and late onset anemia, and as well as a lower requirement for either ESA rescue or blood transfusions. So this is another study which looked in the role of ferric carboxymaltose in non-hemodialysis CKD patients. And this looked at the efficacy of for FCM in the correction of iron deficiency anemia in non-dialysis CKD patient. And this was a prospective study which included non-dialysis CKD patients on peritoneal dialysis and kidney transplant patients, around 20%. And the iron deficiency was defined as HB less than 12 in women and less than 13.5 in men, and a T-set of less than 20 or a ferritin of less than 100. which are not responsive to our line therapy. And these patients were given IV ferric carboxymaltone 500 milligram as an infusion over 15 minutes, and they're followed up for 6 months. And the visits every monthly visits with monthly visits, and the target ferritin was around more than 100, and T-sat more than 20. So accordingly, patients were given subsequent doses on their monthly visits. So primary endpoint was the achievement of a target T-sat and the ferritin of more than 100, and venous hemoglobin more than 11. And again, secondary endpoints, they looked in the changes of ESA doses, which was calculated at the beginning of study, and with compared to the baseline dose. And a subsequent subgroup analysis was also done to compare the changes of hemoglobin, T-sat as well as ferritin in patients, which is stratified by the clinical setting. So what they found was that the T-sat as well as ferritin levels promptly increased within the first 4 weeks of therapy, and they remain constant thereafter. And around 44% of patients had full recovery of iron deficiency, and they reached their targets. And in particularly, around 14% required only one dose of iron ferric carboxymaltone, and two doses were required in 42%. So they also look into the second efficacy at ESA dose during, again, those who received and therapy reduced fewer doses of ESA than at the baseline. And again, subgroup analysis showed that mean increase in anemia from the baseline to evaluation period was similar in kidney transplant, PD, as well as non-dialysis CKD patients. And the changes of hemoglobin iron parameters were unaffected by the ESA use. So, concluding what they found was that the treatment of ferric carboxymaltose in non-dialysis CKD patient resulted in a significant improvement in hemoglobin and parameters at 24 weeks as compared to baseline. And these changes are independent from the ESA use and the clinical setting. And the ESA doses also significantly could be reduced in those patients who received ferric carboxymaltose. So again, this was another study which looked into safety and tolerability of ferric carboxymaltose, and they found that there was quite safe to use ferric carboxymaltose with mild and transient adverse effects like metallic taste, headache, and dizziness. And compared with other intravenous iron preparations, they require only shorter administration time and reduced, and this may reduce the cost also because of fewer treatments were required. So summarizing, I would like to say that post-transplant anemia is a common complication after kidney transplantation, and though it is less often discussed, and it has got serious consequences in the term of decreased post-graft survival, patient mortality, as well as the cardiovascular events. And the main risk factors for post-transplant anemia, it depends. It varies according to the timing of transplant. Early transplant, it is due to the iron deficiency. Later on, the graft function is most important. Again, infections, drugs may also contribute to anemia. And the iron studies are quite difficult to interpret in the first post-transplant year because of the coincident inflammation, which might affect the serum ferritin and T-sat values. Again, treatment of post-transplant anemia should begin as soon as possible after transplantation. And the treatment involves use of erythropoietin stimulating agents and iron therapy when there is evidence of iron deficiency anemia. Thank you.